What I'm going to do is hopefully give you guys some insight as to what my job deals with on a day-to-day, working in oncology. I've been with oncology for almost 5 years now, and I love it. It is a great mix of general practice feel with specialty practice feel. I get to see the same clients over and over again, which I love building that relationship with clients. But again, the specialty medicine part of it is very exciting. It's more than just your puppy kits and your spays and neuters and things like that, which can get very humdrum. What we're going to start with is just kind of a general overlook of cancer. When you tell an owner that their pet has cancer, what exactly does that mean? Well, first of all, it means that they're not uncommon. Each year we have quite a few pets that are going to die from cancer. Unfortunately, it's the leading cause. That generally translates to 47% canine, and 32% feline. So if your dog lives long enough, you have 2 dogs, one of them's going to probably die of cancer. It's almost a 50% rate. In the United States, that means over 8 million cats and dogs will develop some form of cancer each year. Most of my patients are going to be senior patients, but I see them of all ages. And so, again, I say if they live long enough, but sometimes that's 3, 4, 5 years old. So what is cancer exactly? You have a client that comes in, they say, I have a lump under my dog's throat, or I have a mass on their belly. Well, all those things mean cancer, unfortunately. So it's a lump, a bump, a tumor, a mass, a growth. The technical term is neoplasia. But all of those kind of mean cancer. And what that means is where normal cells in the body have started to divide and replicate erratically the way they shouldn't, and they are now going through unrestrained growth. Sometimes that's a slow growth, sometimes that's fast growth. It can occur in any body organ, so literally from nose to tail we can see cancer show up. It can travel throughout the body in the blood and lymph system. There are more than 100 types, unfortunately, so that's a lot of different diagnosis. And it can include both malignant and benign. Dr. Vansel, who's the oncologist here, he typically has an explanation of malignant and benign, being that cancer is going to cause a problem, whether chemically it is aggressive or not. If it's malignant, that's the worst kind typically, and that's what we all know as cancer. But there are benign things out there that can cause a problem. There's lipomas that can get the size of basketballs, and they can grow in the muscle. Are they chemically dangerous? No, they're not, but they're still going to cause a physical problem. So there's very few benign things that we deal with, but even the benign diagnoses are considered cancer. So with us, we're usually the front line with the clients, especially in our general practice. We're putting them in a room, we're getting a history on Fluffy with Mr. Jones, and they want to know, why did my pet get cancer? What did I do to cause it? Well, they didn't cause it, and that's important for them to know, and that's something that we can educate them with. It is not the owner's fault. They didn't feed them the wrong diet. They didn't have the wrong type of vaccine schedule. I've heard all kinds of things that they think they did to cause it, and they didn't. There are several environmental and genetic factors, and we're going to touch on a few of those here in a minute. Any and every breed or mixed breed can get cancer. I think that there's a little bit of a notion where I don't want to get a purebred dog because they die of XYZ faster. Well, that can be true in some breeds, but I have plenty of patients that are mixed breeds that come in with various types as well. And despite some factors associated with it, exposure to these factors may not be the only reason. Pets just get cancer for whatever reason. So the first thing we're going to touch on is nutrition. This picture here is something everybody's seen in practice, of course. But what it's going to highlight is obesity. Obesity is going to create an inflammatory process in the body that non-obese animals don't have. If you have an extra problem, we'll say, plus cancer, then that's going to make fighting cancer that much harder. So obesity can lend itself to problems when they're undergoing chemotherapy or problems with just their medical outlook on general. It can make our job harder because if we have a 120-pound lab that we need to dose chemo to, and he should weigh 80 pounds, that's a risk that we run to overdose them. So we have to be very careful when we're doing our chemotherapy doses. And then again, it just creates a secondary problem for their body to adjust to. It's one thing to have diabetes or kidney disease or heart disease. It's another thing to have any of those plus cancer and being overweight on top of that. So like I said, obesity can actually lead to issues and can lead sometimes to the body having that inflammatory process which can promote cancer. What is their medical history? In cats, If there is a feline leukemia virus positive cat, they have a greater risk to develop what's called mediastinal lymphoma, for instance. Mediastinal lymphoma is going to live in the cranial part of the chest. It's going to present breathing difficulty, respiratory changes, things like that. Also with cats, do they have IBD? IBD and GI lymphoma go hand in hand in a lot of cases. Again, it's that inflammation. So the GI tract is angry, it's inflamed, it's causing vomiting, it's causing diarrhea. And just the lining of the GI tract stays in that inflamed state. And again, inflammation can lead itself to creating cancerous lesions such as GI lymphoma. And then specifically with cats, we see vaccination site sarcomas. So this is not as prevalent as it was 20, 25 years ago when vaccines weren't as clean as they are nowadays, but we do sometimes see vaccination site sarcomas, and we've even seen a handful of convenient site injections, steroid site injections, just the injection site itself, not necessarily linked to a vaccine, but again, most of them are vaccine related. And again, the medical history with canines, we see that some benign rectal polyps can turn into malignant colorectal cancers. We can also see any kind of fracture repair on long bones can sometimes lend themselves to turn into an osteosarcoma. So again, what's the medical history of that patient? Spaying and neutering, which everybody preaches about, have your dog spayed or neutered. Very, very important with female dogs. Female dogs spayed prior to their first heat cycle have a huge reduction in their risk of developing a malignant breast cancer. If they are not spayed, they go through one heat cycle, their risk is going to go up by 26%, and it's going to keep going up with each one. If you have an intact female dog, she's going to have a mammary mass of some sort at some point. Spaying them, just another great reason to spay our pets, is a way to reduce that. Male dogs, you can eradicate the risk of testicular cancer by neutering them, which is a duh kind of moment. Take it away, they can't get cancer. But that does not mean they won't get prostate cancer. And most of my patients that come in with prostatic carcinomas are in fact neutered dogs. What are the physical factors of their environment? So if you get that cat that comes in that smells like a freight train because their owners smoke 3 packs a day, they're going to be at a higher risk. And the reason for that is, just like we would inhale secondary smoke, those cats are getting on their fur, and you smell it. You can smell it on your hands when you have to restrain them and things like that. Well, those cats are ingesting that when they're grooming themselves. And so those type of households, those kitties come in with GI lymphoma or chest mass or something like that. And again, that's an environmental factor that contributes to that. Another environmental factor is sunlight. So all of your little pit bulls that are white, your white and fawn boxers, your white cats, those are going to be more prone to some sunlight-induced squamous cell carcinomas. And I've got a few pictures of that coming up. Again, it's just no pigment. It's just what their genetics are going to lend them to. And typically, these squamous cells are going to be on their face, on their ears, and then on dogs, it's going to be on their belly or in their inguinal region. And again, I mentioned the osteosarcoma can sometimes present in a dog that has a plate or a pin or something like that, some kind of trauma that's associated with the bone early on in life. They have it repaired and they keep that their whole life, but there's inflammation around that repair. Again, that can sometimes turn into an osteosarcoma of that bone. These are some pictures of, like I said, those squamous cell carcinomas. So you can see that these are circled here with Sharpie, which is a wonderful tool to use, just outlining the margins or the area of concern there. Again, this is a large squamous cell here. It's a little hard to tell on the picture, but right in this area here, right up next to where the prepuce is, that's where the inguinal lymph nodes are going to live. And on this particular dog, they were quite large, probably like lime to lemon size lymph nodes, and those were positively metastatic for this squamous cell carcinoma that's living right here. And again, your white cats, so this is a nice little nasal lesion here, some ear tip lesions here, and again, it's your white cats that are not, baking in the sun for 8 hours a day while you're at work. Genetics can play a role as well. A few breed notations I'll mention are going to be your flat-coated retrievers, which are wonderful, very sweet dogs, but unfortunately, they almost always come into me with a malignant histiocytosis. Another type breed of this same diagnosis is going to be a Bernese Mountain Dog, very, very prone to histiocytic sarcomas that can be commonly found in the spleen or in the abdomen somewhere or in the chest. Scotty dogs and Westies If they come in with any kind of hematuria, my first thought is a bladder tumor. Those dogs, again, genetically are just prone to those. Siamese cats can have a higher prevalence of mammary carcinomas and intestinal carcinomas. Subjectively with genetics, and I hate to say this, I know there's been a story here recently about the creator of a labradoodle. A doodle of any sort is going to get cancer of some sort if it lives long enough. I typically will see a doodle at anywhere from 2 to 8 years of age. They can have anything from lymphoma to splenic mass to leukemia. Unfortunately, like I said, that breed is just prone to developing some sort of cancer. And with that comes golden retrievers. They're a big component in that, and golden retrievers, unfortunately, we see for lymphoma and liver neoplasia quite a bit. I think it's the same as any breed. I think that there's so much attraction to it because it's a great family dog. They don't shed. They have great personalities. You can make them in any size, shape, and color that you want to. You can mix an Aussie Doodle. You can make an Aussie Doodle or a Bernedoodle. I've seen a German Shepherd Doodle. All the things. And they're supposed to have these wonderful personalities. And so I think there's such an influx of that these chronic cases of cancer are kind of falling by the wayside. I just don't think there's enough public outcry, if you will, for that right now. Plus, if you think about it, with boxers and pit bulls, knowing that they're kind of tumor factories, they've been around for hundreds of years. Comparing a doodle that's been around 10, 15 years, we just haven't had that time to come up with yet. But yeah, like I said, any kind of doodle will develop something. So now that we know it has something, regardless of what caused it, we want to start with a diagnostic workup. And these are things that you guys can do at general practitioners or that I can do where I'm at. But we want these done to help stage our pet. People, when a person is diagnosed with breast cancer or prostate cancer or what have you, they're going to stage that person. And we're going to do the same thing in dogs and cats because we want to know at what degree it is it anywhere else? Can it be removed, so on and so forth. So up front, again with the education of the client, you want to let your client know that there's going to be a lot of steps into confirming what your pet has, to diagnosing what your pet has, and getting you the proper plan of treatment. It is almost impossible to formulate an accurate plan without those steps and without having that definitive diagnosis. And like I said, there's steps to get that. One thing that you guys can utilize as a tool, and it will improve your clientele's impression, I do believe, is using this body map. So when you have that Labrador that comes in that's got 20 lipomas all over him, you want to start to map that. And what that means is it's the day that they come in, you make measurements of each lump and bump, and you can even characterize them. Soft and squishy, hard and cauliflower-like, lives on top of the skin, lives underneath the skin, those type things. Because when you see that next patient 6 months later, 8 months later, or a year later, and they say, hey, I think he has a new bump, you can reference that body map and you'll know, no, this bump was already here. It was 4 centimeters a year ago. It's only 5 centimeters now. I think that's okay. But without this body map, like I said, that's hard to do. And I think that's a tool that technicians can use to help their clients. So our basic staging tools for working up a cancer diagnosis are going to be these items here, and we'll touch on these. So your physical exam, your blood work, your x-rays, in some cases ultrasound, in some or most cases cytology and biopsy, and again CT scan we also use here at our office. And then some diagnoses have a special diagnostic tool that goes with them. Heart mass is a dog that's throwing BPCs, we can run an EKG on, and flow cytometry is a test that's with our lymphoma diagnosis. So we'll touch on those. So our physical exam, again, similar to our yellow labs from earlier. Have there been any recent changes in weight? So if you have a cat that comes in that a year ago on their physical exam weighed 15 pounds and now we weigh 9 pounds, it's almost a 50% drop in weight. That's significant. And if the owner says, I haven't been feeding anything different, I haven't been feeding an amount different, well, that's significant. And that's a significant finding on the physical exam. What is the overall condition of the patient if cancer wasn't there? So if you look at Fluffy, and Fluffy is also a diabetic, also in kidney failure, that's significant to our diagnosis because, again, those patients are going to have a harder time fighting off whatever cancer diagnosis they have. Where is said mass or said cancer located? So is it on the toe? Is it on the ear? Is it inside the abdomen on the spleen? Where is it located? And again, that's a tool, the physical exam will help you to determine that. And then how big is it? Again, kind of talking about our body maps for skin masses. We also use how big is it for our lymph nodes when we're talking about lymphoma. All right, on our CBC, chemistry, and UA, we typically would want the big chemistry, 20, 25 values, something like that. This is going to be the baseline for any medical issue, as you guys know. Some things that I see commonly, first of all, is going to be anemia. We'll get a regular vet that will call Dr. Vansel and say, I've got this really anemic patient, I think something's going on. What's the hematocrit? It's 37. It's pretty normal for me. Usually my patients, whether they are just newly diagnosed or they're undergoing chemotherapy, anemia is going to be kind of normal for my patients. And so anywhere in that 32 to 37, although that is low, again, that's pretty normal for my patients. If we're talking about a hematocrit of 17, it's totally different. That means something is bleeding somewhere pretty acutely. On your chemistry, you may see that you have an elevated calcium. That's pretty common in our lymphoma diagnoses as well as our anal sac tumors. And that's one that gets missed pretty commonly. If you have a high calcium and you haven't had your vet do a rectal exam on your patient, start there. There's a good chance you're going to find some form of rectal mass. Again, seeing that calcium is a pretty big trigger for that. And then the glucose level. If you have a patient that's coming in with a normal glucose of something in the 40s or 50s, obviously not normal. Typically that's going to indicate something like a pancreatic mass such as an insulinoma. When you are catching your urine sample, free catch is totally fine just to do a screening. If you are obtaining a urine sample due to suspicion of a bladder mass, do not use the cysto. With bladder masses, when you stick a bladder mass with a cysto and you come back out with your needle, you can actually take some of those cancer cells and pull them through the body wall, pull them through the skin, and they will seed, is what we call that. They'll set up masses in the body wall and in the skin. So again, if you have a Westie or a Scotty dog and you suspect a bladder mass, do a free catch. Do not do a cysto. Chest x-rays. This is a biggie that I like to preach on. So standard of care for looking for metastasis or spread of disease from one body organ to the chest is going to be 3-view chest. Never do 2 views. You need a right lateral and a left lateral and a VD. Very often we'll have a right lateral and a VD sent. We'll take a left lateral and we'll see a mass sitting over the heart. It's very common. So again, if you have a cancer diagnosis and you're doing your staging, standard of care is going to be 3-view x-ray, not 2. For the abdomen, this is not a tool that's necessary. For the abdominal masses, you can do a confirmation x-ray. So you can take an x-ray, a lateral, and you can see that there's something bulgy in the cranial part of the chest pushing on the diaphragm. Likely going to be a splenic tumor or a liver mass, but you won't know the difference until you do an ultrasound. So again, you can have confirmation x-rays for suspicion of an abdominal mass, but it's definitely not the standard. Ultrasound is going to be your standard for anything in the abdomen, from diaphragm to tail, is what I usually tell people. So splenic masses, liver masses, anything in the urinary system, any kind of lymph nodes or GI thickening in a cat. Again, like I said, your ultrasound is going to be your best bet. And again, with your ultrasound, with your sampling, sometimes we'll get samples with ultrasound such as some of our liver masses, or if we want to look at lymph nodes, but any kind of bladder mass or splenic tumors, we don't want to run the risk of a splenic mass rupturing, whether it's malignant or benign, because of course that would create a hemoabdomen. And then again, we talked about seeding. And this kind of shows you what a bladder mass will look like. So typically the bladder is going to be a big, nice balloon. Everybody's seen it. It's uniform. However, this is going to show you that on this bladder wall, a big tumor is growing. And you can see these measurements here on this axis. That's what a typical bladder mass is going to look like. So your next tool would be cytology versus biopsy. And there's some pros and cons to each. The pros of a cytology is it's fairly cheap. Dog can be wide awake while it's happening. It's pretty easy to collect with just a needle and a syringe. And if you send it to our lab here, or if you look at it under the microscope, if your doctor does, it's pretty quick turnaround. However, it can be very vague. One of the favorite quotes of our cytologies we send in will be suspicious of neoplasia. Well, we knew that. We knew it was a neoplastic lesion. We just want to know what it is. And a lot of times cytology is not going to give you that answer. And again, we may want to take this lump bump tumor off anyways. So you would not necessarily be wasting the client's money, but again, we're going to have the recommendation to take it off anyways. If you're going to take it off, test it once, that sort of thing. We, of course, would then look to our histopath and biopsy. A pro, of course, is going to be very accurate diagnosis. We can look at margins, which our surgery team does for us quite well. They'll sometimes ink the sample, and that's going to help to illuminate the margins for the pathologist. And so again, like I said, that's a huge pro because sometimes it's curative. A lot of times that's going to be your lipomas, some of your low-grade mast cells, some of your low-grade soft tissue sarcomas. When you take that off, it quote-unquote cures the patient. And then, of course, the cons are, obviously, it's more expensive. Your dog, cat needs to be asleep. There's a larger turnaround time with these samples and an even larger turnaround time with big samples. So I mentioned bone, entire limbs, spleens. That can sometimes take up to 2 weeks to get the sample back. By the time they're coming in for a suture removal, we're still looking for the results. That can sometimes happen. So you need to, again, just forewarn your owner, hey, we're not going to have this back tomorrow by any means. We'll reach out to you when we do get it back, but it could be 10 days, 2 weeks if it's a larger sample. And then, of course, the surgery recovery time. That can vary, of course, to a couple of hours, going home the next day, to a splenectomy that has complications that goes home 3 or 4 days later. We have CT, which is my favorite tool. So the best way we can describe a CT is you're taking XYZ body part and you look at it like a loaf of bread. What the CT is going to do, if you have a whole loaf of bread, or in this case a whole canine skull, a CT is going to make slices like you would have a loaf of bread make slices. And the radiologist, is going to take a look at all those individual slices and look at the difference between them. And this is down to the millimeter. So you can imagine how tiny these what we call slices are. And each slice is an X-ray. You can think of it that way. And so together, when you put this together, you get a full body part. It can be costly. It's not cheap to run these. Typically, you're going to see them at universities or, like I mentioned, with specialty hospitals, us, and I think Blue Pearl also has one. This is a standard for radiation. With radiation planning, which we do not do here, we typically outsource ours to either UT or Atlanta. With radiation, they use CTs to plan where that radiation beam is going to go. So you do need a CT for that. And of course, it is going to require the patient to be under anesthesia or at a very minimum heavy sedation. Our CT here, a Labrador skull from nose to kind of base of the neck. Total turnaround with anesthesia and everything is about 25 minutes. But the scan itself takes about 2 or 3 minutes. Your patient's not going to sit there and just keep their head perfectly still. So again, anesthesia is necessary. And this is a favorite tool of mine. So this is one of those slices. If you kind of chop the head off in the middle, which sounds gruesome, but if you did, this is what the tumor would look like here. And as you're going up and down on that head, it's going to get smaller and smaller as you get to the bottom of the tumor, bigger at its middle point, just like a ball would. This is that same tumor right here. So it's growing off the zygomatic arch, off the eye socket. And again, this is just another slice if you're going from top of head down. So again, CT's a great thing. So what is our diagnosis? We've done all that workup. We've done all of those diagnostic tools. What does Fluffy have? What are we going to tell Mr. Jones that Fluffy has? So all neoplasia is going to fall under 4 typical categories: round cell, sarcoma, carcinoma, and melanoma, which is all by itself. This cytology here is of a spindle cell sarcoma. These little wispy tails here are spindle cells, is what that's called. And those little tails are pretty indicative of some sort of sarcoma. So if you're doing cytology in your own clinic and you see these nice little tails coming off, you know you're in the sarcoma family. We're going to break down kind of, if you have a lump, bump, tumor, mass, whatever, and it's in XYZ skin system, what do you probably have? So the next few slides are going to go through what you can diagnose kind of in the back of your head, or what your regular vet can diagnose in the back of their head based on where it's at in that dog's body. So we're going to look at skin, skeleton, the GI tract, the reproductive system, general abdominal organs, some blood type tumors, and then some miscellaneous tumors as well. So we'll start with skin. Your malignant type of neoplasm is going to be your mast cell tumor, which everybody's seen if you've been in practice long enough, and some soft tissue sarcomas as well. We again can have quote-unquote benign cancers, as long as they're not causing a problem, which would be your lipomas, your adenomas, your papillomas, skin tags, things of that nature. This is a nice representation of a mast cell tumor right on top of the skin there, pink, fleshy, angry, typical presentation for a mast cell. And that's where we're going to start. So this is the most common cancer of skin origin, and in dogs. It's the second most common in cats, believe it or not. With mast cell tumors, we can easily diagnose a mast cell tumor by cytology, and I've got a slide as to what that cytology will look like. Nice pretty granules in the cell. However, you cannot get a grade on the mast cell tumor, and mast cell tumors are graded 1 through 3, 1 being the best, 3 being the worst, and that grade only comes from taking the entire mast cell tumor off and sending it into a pathology lab. In most cases, mast cell tumors that are unchanged and have a long duration are generally lower grade. We've had some patients that have had mast cell tumors taken off that have been there for years. Those are generally a low grade 1. They're just kind of sitting there slowly growing, not causing much of a problem. Whereas you have a mast cell tumor that's there for 2 weeks and has tripled in size, that's an aggressive hot tumor, and that's gonna typically have a higher grade to it as well. Some of the negative prognostic indicators of mast cell disease are going to be if there's any lymph node involvement, and I've got a few pictures of that as well. Have we had surgery and 2 weeks later we already have some little bumps growing back? That definitely happens, obviously negative prognostic indicator. How big is it and where is it? Any of your mast cells that are near reproductive organs such as perivulvar, periscrotal, mucous membranes, we've seen those. Those are going to have a lower prognostic indicator and typically be more aggressive as well. The good news is those low-grade ones that we take off can be curative. Typically, you're going to want wide margins, as with anything, but again, they can be curative when you take them off as a low grade. With grades 2 and 3, we are typically offering chemotherapy of some sort. Our 3 chemotherapies, first of all, standard of choice is going to be vinblastine, which is a series of 8 injections. They are weekly for 4 weeks and then bi-weekly for the additional 4 treatments. We can also use a drug called lomustine that is given every 3 weeks for about 6 treatments. And then there's a drug called Palladia, which is fairly newer on the market. It's come out the last couple of years. It is specifically for mast cells as well. It is something given at home, but is typically only available through an oncologist. Palladia is a growth inhibitor. It's not a true chemotherapy, excuse me. It is a coated tablet as well. We typically prescribe these with gloves for the owner, and we do put on the label, administer while wearing gloves, do not break or crush, things like that.
Can they go to like a human pharmacy and just get it?
They cannot. Palladia is specifically in the veterinary world, and it is specifically available to oncologists only. I think that they have started, I want to say probably like 6 months or so, I think there was an online pharmacy that somehow got that, but they shouldn't have, I'll put it that way. And so as far as I know, it is only available through an oncologist as of right now.
Thank you.
You're welcome. With mast cell tumors, we're also going to be using prednisone, Pepcid, and Benadryl. If you guys have a mast cell tumor you're referring to me, send it to me on Benadryl and Pepcid. It's unusual to me that regular vets will send us mast cell tumors and ask, are they on anything right now? And they're not on a darn thing. Pepcid, Benadryl, it's almost like water. It's so easy to get, it's so easy to give, and it will help them tremendously. With our Pepcid dose, we're using that at 1 milligram per kilogram orally. And with our Benadryl dose, it's your standard 1 tablet per 25 pounds. That can be given 3 times a day if needed. And like I said, all mast cell tumors that are of a higher grade should definitely be coming to me already on this. So this is a picture of what your cytology is going to look like with a mast cell tumor. Looks like confetti in a cell. That's the best way I can explain it, or like a snow globe in a cell. All these nice little purple granules are pretty indicative of a mast cell tumor, and there's a lot of those cells. It's not like all red blood cells in one unusual looking cell. There's tons of these cells that are on one slide. This patient on the left is a great example of how lymph nodes can become involved. Again, if a lymph node is involved, it's a poor prognostic indicator. This is a facial. Again, we talked about facial, mucous membrane type mast cells. This is a mast cell here on the face. This is our left submandibular lymph node, which is huge. The good thing is lymph nodes respond to chemotherapy just like the actual tumor does, but it's quite large. And this, it's a little hard to tell on screen. This is our mast cell here, again, kind of close to our scrotum. This entire area here is an inguinal lymph node that was about the length of a dollar bill. It was huge. Again, that's a negative prognostic indicator. The other type of things that you'll see associated with the skin are going to be soft tissue sarcomas. Typically these are solitary in nature, and these are the lumps and bumps that don't quite feel like a lipoma anymore. They're not soft and squishy and mobile. They're quite firm, like a baseball almost. May not be as big as a baseball, but they're quite firm. They are sometimes pretty attached to the skin, or even the under layers of skin, so they don't move around like a lipoma would. And sometimes they will have kind of a shell that you can feel in there as well. With these, lymph nodes typically don't become affected with these, with the exception of some of the really high grade soft tissue sarcomas, but we see fewer of those. The larger the mass, like halo orange size or bigger, they're not going to respond to chemotherapy very well at all. We can slow down their rate of growth, but we cannot shrink them by any means. Typically a multi-systemic approach is going to be the best. So that's going to be surgery plus or minus the addition of radiation therapy in some cases, plus or minus chemotherapy with that. Depending on how good your margins are, we do see local recurrence with this a lot. So again, if your doctor knows what type of mass it is going in, they need to investigate how big their margins should be, if they can get large enough margins. I'll show you a picture in just a second of a patient where margins weren't even an option because of where it was growing. But if it's on the trunk of the body, if it's on the abdomen, you have that extra skin, try to get as wide a margin as you can. And they can be pretty locally invasive, destroying the tissue where they're at in a lot of cases. These are going to be your fibrosarcomas, liposarcomas, sometimes your lipomas or intramuscular lipomas like I mentioned. This is the leg of a whippet, which there's barely a leg on a whippet anyways. You can see through them almost. And this is a very large soft tissue sarcoma. Like I said, margins were not even an option on this patient. He actually lived with this for quite a while. I want to say upwards of 1.5 years, 2 years. What you run the risk of is this little area right here becomes the thinnest. It becomes real ulcerated, starts opening up and bleeding. And so ideally if you have them on the limbs, the smaller they are, the easier they are to get off. Even if you don't get margins, you're going to avoid, a cleaning bill for the owner, cleaning her carpets up, if you will, with bleeding all over the house. This little guy down here looks like he has a saddlebag. It's pretty stretchy. It stretched his skin out. This one we were able to get pretty good margins of. Again, that's an example of kind of where it's at, your surgical approach. That one, again, low grade, it's growing pretty slowly, but it's grown to this size, but we can get nice big margins on it. Next system is the skeletal system. Most of these are going to be osteosarcomas that you guys will see. They typically will be 85% of what type of cancer we see associated with the bone. They can occur in any long bone. Typically you're going to see distal femur, so closer to the knee. You'll see your proximal humerus, so closer to the shoulder, things like that. With radius and ulna, they can kind of be seen anywhere on the radius and ulna, although I will say typically they're distal as well. We can also see these in the jaw. It's pretty common there, and in ribs. Very rarely do we see them in the pelvis. Large and giant breeds are pretty represented in this scenario, so your Great Danes, your Greyhounds, some large Labradors, those are going to be the ones that typically present with an osteosarcoma. What you guys would see is just an unusual swelling of the bone. When you take an x-ray, you're going to see this moth-eaten appearance that's here. You can also sometimes see this here, which is just like a patchy type of appearance. It's not necessarily hollowed out, but it's just real patchy in the bone. Most commonly, what we're going to recommend if it's super painful and we're running the risk of a fracture is going to be our surgery. Although I will say with osteosarcomas, if they're caught early and we can get chemotherapy on board, we actually don't recommend amputation right away. With osteosarcomas, we've found that if they can keep the limb that's affected, the cancer kind of stays stationary to that limb. Once you take the limb away, there's still cells in the body, and that's when it tends to spread. So if you can, with your osteosarcomas, if they're not painful or if they're managed, if they have their pain managed, with your NSAID, gabapentin, tramadol, combination, then the longer they can hold on to that leg, actually the better for their outcome. We do sometimes offer radiation palliatively if we have using a Great Dane as an example, if they have a distal front leg osteosarcoma and they have really bad hips, then they're not necessarily going to be an amputation candidate anyways. And so you can offer radiation as palliative pain control and to slow that growth down. The next items are going to be your gastrointestinal tract. So literally from your mouth to your back end, we see various types depending on where we're at in that tract. Your oral tumors are going to be fairly low, 7% canine, 3% feline. Almost none of the gastrointestinal cancers are going to be represented by the salivary glands or by the esophagus. Very few also with gastric. Intestinal is going to be a lot with cats. We talked about intestinal lymphoma with them. And then again, perianal, we're going to count that perianal anal sac area as sometimes a higher prevalence as that as well. So oral tumors. I think you guys, especially you guys that do dentals, are great at finding these. I know whenever I was in GP, if I was cleaning teeth, I'd be back around the last molar or something, and I'd see a mass that the doctor never saw because they haven't come to do their dental exam yet, or they couldn't look at the dog's mouth very well prior to the dental. So malignant melanoma is going to be pretty common as your oral tumor. If it is black in color, it's going to be of the melanotic type, which is 67%. It can also be pink and fleshy and not have any pigment, which is about 33%. Melanoma is nasty, and it is ugly, and it takes them very fast. So anytime you see any questionable lesions in the mouth, definitely have those biopsied. Push for that histopath to be done, because the quicker you can catch melanoma, the better. And again, like I said, if it is melanoma, those are in the mouth, almost always malignant. The best treatment option is going to be removing the bulk of the disease. We add in chemotherapy. We can add in radiation. Most commonly, these will come back very fast, and they can affect the lymph node as well. They can make the patient have inability to eat, inability to use their jaw, and that's typically why they are then euthanized. The one thing I'll say about melanoma as well, take your 3-view chest rads. I've had some melanomas that have come to us removed 3 weeks prior to their appointment with us. By the time we see them, we do those x-rays, they've already got it in their chest. It can move that fast. So very important with melanoma to be very aggressive with their treatment plan. With cats, most people have seen kind of the old crotchety cat come in with a funky mouth. Typically with those type of diagnosis, we're looking at squamous cell carcinoma. These can be pretty bad for cats. Unfortunately, there's just not a lot of space in the mouth to do anything with. So squamous cell carcinoma, a lower percentage in canine versus your 70 to 80% feline tumor in the mouth is going to be a squame. They very rarely metastasize to the lymph nodes. However, they are very destructive where they live, and they spread very fast where they live. Surgery, unfortunately, is typically not an option, just again because of space. Obviously, if you have something in the hard palate, it's very difficult to close that surgically. We can see that these can benefit from radiation, which is nice. We also would use chemotherapy in cats specifically to slow down how fast it's growing. But typically with our cats that are coming in, they're not making it to their full potential of 5 treatments, unfortunately. Again, it's just a very aggressive, oral cancer in cats. Some other ones that we'll mention, fibrosarcoma. These are real hard, real bony. Best option with that is going to be radiation and or chemotherapy, surgery if able. And we do, again, kind of getting to boxers, this is one that pops up with them. We see things called epulus. They're real big, pink, fleshy gum tissue. They are quote-unquote benign chemically. However, they can grow and become a problem. So a lot of times we still are surgically removing these as much as we can. A lot of times they like to grow right around the incisors, and we'll typically do a partial maxillectomy or mandibulectomy where we're removing the bulk of the disease. Again, benign chemically, but cause a problem. Therefore, they're malignant in what they're causing. Again, salivary and esophageal tumors are very rare. They are typically going to be very highly metastatic and very aggressive if you do see them. They have a poor prognosis, and obviously with that we're offering palliative care. Appetite stimulants, pain medications, things to help with inflammation, things of that nature. Gastric tumors, they are specifically in the stomach lining called a GIST, a gastrointestinal stromal tumor. They will typically present with vomiting, pretty common vomiting despite your Cerenia, and the reason for that is there is a physical problem in the lining of the stomach. So Cerenia is not going to really help that. Some of these can have surgery to be curative, and they also do respond to palladia, which is the other use for the palladia is mast cell disease. GIST can also commonly respond to palladia. I could talk for an hour on lymphoma. It's what I treat the most, both with dogs and cats. With cats here of the intestinal tract, and some dogs. Again, you're going to have an older cat with weight loss, with appetite loss, vomiting, and they just generally don't look very thrifty. They're not really grooming themselves very much. Ultrasound is going to be your key tool. Again, we're looking for thickened areas of intestinal loops. We're looking for lymph nodes that are large around the intestines. And blood work, when you run blood work, may or may not look abnormal. Very commonly they don't. So again, for GI lymphoma, your best tool is going to be your ultrasound. With canine or feline GI lymphoma, we treat them with drugs of choice just as we would peripheral lymphoma, which I'll get to in a minute, which is the CHOP protocol made by the Madison, Wisconsin school. The last one on our track through the GI system is going to be what's called an agasaca. It's an apical gland anal sac adenocarcinoma. It's a tumor of the anal sac. We can also sometimes see perianal adenomas. They can look very similar if they're growing on the outside of the anus. It's very hard to differentiate on a cytology an anal gland tumor that's malignant versus a perianal adenoma, which is not malignant. So standard of care in that area is going to be to remove the mass and send it off for diagnosis. They will typically, if it is going to be a malignant agasaca, they're going to live right where the anal sacs live at 4 o'clock and 8 o'clock. And we typically will have these removed, although margins are very difficult to obtain. Same as with the mouth, there's just not a lot of extra space back there, so you get bulk of disease as much as you can. Margins are usually very scant, and because of that, we do offer chemotherapy in those cases. This is a lovely picture to end on, no pun intended, of where the anal sac tumor is going to live. Again, this is a left-sided, obviously, anal sac tumor. It's deviating the rectum to where it's kind of pointing to the right because of all the inflammation that's pushing. And you're obviously, again, going to want to do a rectal exam. Make sure it's not an abscess of an anal sac that would express. It would be painful, but it would express. If you're doing your anal sac expression and it's very hard and not expressing, again, we may have a tumor. We very rarely see reproductive tumors, thankfully, simply because we do, in most cases, have such a high rate of spaying and neutering. However, improper neutering, which is a lot of time, not improper, inadequate neutering, which is sometimes seen in shelter medicine, where there's go, go, go. If there is a cryptorchid patient and they're just getting what they can see and that cryptorchid testicle remains, it can turn cancerous later in life. We do sometimes see vulvar or vaginal tumors. They are very, very painful. Very painful. If you're doing any kind of cytology or even just sometimes a simple exam of a vaginal tumor, knock your patient out to where they can't feel it, because they're going to bite you, they're going to scratch. I mean, they're very, very painful, as they should be. And typically with those type masses, surgery is going to be your most common treatment. Again, we talked about mammary tumors. We can greatly reduce the risk of that if you have your female dog spayed. There are some overrepresentation of mammary tumors with purebred dogs and small breeds especially. That's where we see a lot of those. Moderately metastatic. There's, I want to say 7 or 8 types of diagnosis of mammary masses, and so some of those can be more malignant than others. If you have a cat that has a mammary mass, that's not great, to say the least. They have about a 90% chance of that being metastatic. Typically, we would recommend a full chain mastectomy on those cats, followed by chemotherapy, sometimes followed by radiation. They're very aggressive in cats. Again, we talked about testicular cancer. Take them away, they can't get it, but they can have prostate cancer because that's not something that you can surgically remove. Typically with prostate cancer, we are doing chemotherapy plus or minus radiation if we have lymph nodes that are involved. And sometimes we can see that these are actually being hospitalized because they're blocked. They're not able to urinate. And that's mostly the case in male dogs. Just of course the way their anatomy is, their urethra is going to run past that prostate. And if the prostate's enlarged, the lymph nodes are enlarged, it just basically cuts off any kind of urine flow and they appear as a blocked animal. The abdominal cavity itself, most abdominal organs, again, you're going to have kind of a list in your head of what this could be. If it's the spleen, there's a 70% chance it's going to be a hemangiosarcoma. Sometimes we'll see sarcomas of the spleen. We also see hematomas, which are a great diagnosis. I think actually here I see more hematomas than I do sarcomas. But again, hematoma they are great diagnosis. Ironically, sometimes a hemangiosarcoma can be a ping pong ball size or smaller. A hematoma can be a volleyball. And we've taken 11, 12-pound tumors out that look so crazy and so awful, and they come back as a hematoma. So the larger it is, subjectively, the more likely it is it's going to be a hematoma. With the liver, you're going to see hepatocellular carcinomas or metastatic lesions from the spleen if it's a hemangiosarcoma. Again, we talked about the pancreas. If we have a low glucose, we'll typically see insulinoma. And again, with bladder, transitional cell carcinoma. And again, for anything in the abdominal cavity, you want to try to use ultrasound. Hematopoietic are going to be your blood-borne tumors and cancers. This is typically going to be lymphoma. Again, this is what I treat the absolute most of. We will see this in 83% of all blood cancers represented. We can see this in multiple organs. With humans, they have Hodgkin's versus non-Hodgkin's. We do not have that delineation with lymphoma in cats and dogs. Again, breed representation, your Goldens, your Labs, your Doodles, of course, and your Boxers are going to be highly prevalent for lymphoma. And ironically, Dachshunds and Pomeranians, almost never do they have lymphoma, which is kind of nice because Dachshunds come with their own other world of issues, as do Pomeranians with heart disease. With staging lymphoma, the World Health Organization has a clinical staging system. One single lymph node is stage 1 all the way through stage 5, which is pretty much every organ system you have, and that's sometimes a dead dog walking. I would say most of what we treat here at NVS is going to be your stage 2 to stage 3. We do have a handful of stage 4 that do pretty well, but most of all it's going to be your stage 2 and stage 3. We can also see lymphoma in the thymic gland. We can see lymphoma of the skin and of the GI tract, which we talked about. Your most common diagnosed patient of lymphoma is going to knock you down at the door, tail wagging, so happy to be there, but when you go to pet them, they're going to have golf balls in their throat or golf balls behind their knees. Those are their lymph nodes, of course. But they're almost always happy-go-lucky. There are no blood abnormalities whatsoever. They're not painful. They're not having any issues eating or drinking. The owners have just noticed these weird lumps under their jaw or in front of their shoulder blades or behind their knees that have been there for a few weeks. And this is just an example of that. So these are the submandibular lymph nodes here. This is actually a bilobed patient. You can kind of see a little line right here. A bilobed lymph node is going to feel like a packing peanut. It's just got literally 2 lobes on it where that lymph node has kind of separated itself. With outer lymph nodes, you guys are able to feel 5 sets. They're going to be your submandibular, your prescap, your axillary, your inguinal, and behind the knees, which is your popliteal. Any combination of those can be enlarged, although I will say typically we don't see axillary lymph nodes enlarged for lymphoma. Most of the time if you have axillary lymph nodes enlarged, it's because of a different type of tumor that's in close proximity. With leukemia, we can see that feline leukemic patients can, again, run a higher risk for becoming mediastinal lymphoma patients. We see canine leukemia, and this is a big one I wanted to point out. The white blood cell count in a canine leukemia is going to be anywhere from 75,000 and above. These are going to be mostly lymphocytes. This will be probably 80 to 90% of your white blood cell count will be lymphocytes. And I've had one patient this year who her count was at 650,000 white blood cells. Her blood looked like syrup. It was so thick. Her PCV, when we spun it down, her Buffy coat was 7%. I'd never seen anything like it in my life. But again, she walked in and she was feeling pretty good. She just had a little bit of a fever. She wasn't eating right. And she did have a little bit of lymphadenopathy as well. Miscellaneous tumors would be your thymomas, which are in the chest, your heart-based tumors, which are going to be very rare, but typically poor prognosis. They're obviously in the heart. They're usually going to be your hemangiosarcomas, which may mean that we also have hemangiosarcoma of the spleen, for instance. Ocular and sinus tumors, we don't see very many of those. Typically we'll do a CT with those because they're usually growing inward into the skull and actually creating more of a problem than what the owner can see on the outside. And I'll do a quick case study. My absolute favorite patient was Tubbs. He was a 7-year-old male neuter labradoodle, presented to the RDVM for some limping and associated swelling of the distal radius and ulna. The regular vet did blood work, x-rays, and the surgical biopsy for us to get the diagnosis. And when he came to us, they wanted to do anything and everything they could to preserve the leg. I'll show you why in just a moment. So Tubbs went to the University of Florida to get stereotactic radiation on the lesion instead of amputation. They basically put a certain type of plate on the lesion and radiated that plate and bone. He did end up passing away at 23 months from diagnosis, but that was almost 2 years from the diagnosis of cancer. If you can tell your owner, hey, your dog has cancer, but I'm going to give you 2 more years with him, that's huge. Because most of the time, owner hears, hey, I have cancer, they expect it to be dead next week. Again, he got 23 months of life. This is Tubbs, and this is Tubbs' owner, Eddie, who was a paraplegic. So that's why they wanted to keep his leg as long as they could. They were best friends. Tub and I were best friends. Even when his leg was cut off, he would jump up on the x-ray table for me. He was great. But again, because his owner was paraplegic, they tried to spare the leg as long as they could. So he was great. Case study number 2 was Boots Randolph. He was a 10-year-old male-neutered English bulldog, presented to his regular vet for one lymph node that was enlarged that would not respond to any antibiotic therapy and go away. So they actually removed that whole lymph node, sent it off for biopsy, and it did come back as multicentric B-cell lymphoma. When he came to us about 3 weeks later, he had a few other lymph nodes that were enlarged. I think his popliteals and his prescaps were enlarged. The left prescap. We did initiate therapy with him, which was 6 months of the CHOP protocol. And again, diagnosis to death was 23 and a half months, almost 2 years. That's Mr. Boots. And our last one is Belle. She was a 10-year-old female spayed German Shepherd mix. She presented for just expressor anal gland. She's been licking back there to the regular vet. Regular vet did find a firm swelling on the right side of the rectum that was unable to be expressed and did not respond to 2 weeks of antibiotics, so she was taken to surgery. The biopsy of the mass after her workup did come back as an agasaca of the right anal gland. She had chemotherapy and pain management, and again, diagnosis to death was 17 months, almost a full year and a half there of extra life for her. And I point this out because both of these were on the day of her chemo, and this is what most of my patients look like. If my patients were running around naked because they lost all their hair and profusely vomiting because I gave them chemo, I would not have a job. And this is exactly what most of them look like each day. They are happy-go-lucky. They may have a little bit of a dip in their appetite due to the chemotherapy, or just not want to go on their 2-mile run. They just want to go outside and kind of meander and come back in. But like I said, they don't lose all their hair. They don't get profusely sick. And they usually typically look like this. This picture right here was actually taken in our lobby the day she was getting chemo. And that is it. Any questions?